For the longest time, if you had a blocked artery in your heart, the answer was pretty much always the same. Open heart bypass surgery. A massive operation. But what if? What if you could fix that artery from the inside, with just a tiny entry point in the arm or leg? Well, that is the incredible idea behind what we call Percutaneous Coronary Intervention, or PCI. Today, we're going to trace the story of how this procedure went from a wild concept to one of the most common medical treatments in the entire world.
Okay, so here's our game plan. We'll kick things off with the origin story, then we'll walk through exactly how the procedure is done today. We'll get into the amazing toolbox cardiologists use, and of course, look at the outcomes, the good and the bad. Then we'll hit that big question, PCI or surgery? And finally, we'll take a peek at where this technology is heading next.
Every revolution starts with a truly bold idea. And in cardiology, that idea was, hey, maybe we don't need to crack open the chest to get blood flowing to the heart again. Let's look at the pioneers who made that idea reality.
This timeline really just lays out the incredible pace of innovation. It all starts way back in 1964 with Charles Daughter, who first proved you could do this in leg arteries. Then, a little over a decade later, in '77, Andreas Gruenzig took that concept to the heart, performing the first ever coronary angioplasty. But the real game changers were the inventions that solved the biggest headaches. Stents came along in '94. Think of them like a scaffold to hold the artery open. And then, in 2003, drug-eluting stents arrived, which just took the safety and effectiveness to a whole new level.
And the impact has been, staggering. Today, right here in the United States, over 900,000 of these procedures are done every single year. To put that in perspective, that's more than double the number of traditional bypass surgeries. It has completely reshaped how we treat heart disease.
So, we've covered the history, but how is a PCI actually performed today? Let's break down the modern procedure, step by step. It's a surprisingly elegant process when you see how it works.
It really all boils down to 4 key steps. First, the cardiologist gets access through an artery, usually in the wrist, the radial artery, or the groin. Second, a super thin, steerable wire is carefully guided across the blockage. This guidewire basically becomes the rail for everything else. Third, the treatment itself. A tiny balloon is inflated to crack open the blockage, and then a stent is put in place to prop it open. And finally, all the tools are removed and the little access site is closed up.
Okay, so here's a really important distinction. The balloon angioplasty doesn't actually remove the plaque. What it does is stretch the artery and basically squish the plaque against the walls. The problem is, the vessel can try to spring back to its old shape. We call that elastic recoil. This is exactly the problem stents were designed to solve. They're a permanent metal scaffold that locks the artery open and pins down any little tears, which just massively improve the safety and success of the whole thing.
Now, you can't just go poking around inside someone's arteries without doing something about blood clots, so there's a multi-pronged attack. Patients get medications like aspirin and a P2Y12 inhibitor. These make the platelets in your blood less sticky so they don't clump up. At the same time, during the procedure, an anticoagulant like heparin is used to prevent larger clots from forming on all the equipment. This combination of drugs is what makes the whole thing possible.
But let's be real. Not all blockages are simple, soft plaque. For the really tough, challenging cases, cardiologists have a whole toolkit of specialized gear. Let's look at what they pull out when a simple balloon and stent just won't cut it.
Even the stent technology itself has had a major evolution. The first drug-eluting stents, or DES, were a huge step up from bare metal ones. But the second generation, even better. They use newer drugs, they're built on more advanced designs, and the bottom line is they work better at preventing the artery from re-narrowing, and they come with a lower risk of nasty complications, like a clot forming inside the stent.
So what happens when a blockage is basically rock hard with calcium? You can't just push a balloon through that. For those cases, they have something called rotational atherectomy. The best way to think of it is like a microscopic diamond-tipped dentist's drill. It spins at incredibly high speeds and just sands away that calcified plaque, carving a channel so that a balloon and stent can finally get in there and do their job.
And the toolkit has other cool gadgets too. During a massive heart attack, a special catheter can be used to literally vacuum out the blood clot that's causing the whole problem. And when they're working on old, crumbly bypass grafts, they can deploy a tiny filter basket downstream to catch any debris that breaks loose. Each tool is designed to solve a very specific problem.
All right, so we've seen all this incredible technology, but what are the results? When a procedure is this common, you have to have a really clear-eyed view of its success rates, the potential risks, and the long-term challenges.
The immediate technical success is, frankly, remarkable. In 95 to 99% of cases, the procedure does exactly what it's supposed to do: open the artery and get blood flowing again. Now, sure, some really complex cases have lower success rates, but the overall effectiveness is just incredibly high.
This chart right here, this tells the story of the biggest long-term fight. The fight against restenosis, which is just a fancy word for the artery re-narrowing over time. With a balloon by itself, it was a huge problem. Bare metal stents were a big improvement, cutting that rate way down. But drug-eluting stents, that was the revolution. By coating the metal scaffold with a drug, they just crushed the restenosis rate, bringing it down to that 5 to 15% range. It's a perfect marriage of a mechanical fix and a biological one.
Now, while it is rare, the most feared complication is something called stent thrombosis. That's where a blood clot forms inside the stent. It only happens in about 1 to 3% of people, but when it does, it can be life-threatening. This is why it is absolutely critical for patients to take their dual antiplatelet therapy, usually aspirin plus another pill, exactly as they're told. Stopping those meds too early is the biggest risk factor.
This all leads to one of the most important debates in cardiology. If a patient has a lot of blockages, which is the better route? The less invasive PCI or the more durable bypass surgery, which we call CABG? Well, the answer, it's complicated.
And it's not a decision that's made in a vacuum. The modern way to do this is with what's called a heart team. You get the interventional cardiologist, the cardiac surgeon, and the patient's main cardiologist all in a room to discuss the case. They look at all the angles to figure out the absolute best strategy for that one specific patient.
So what does the hard data tell us? Big clinical trials, like the ones called Syntax and Freedom, have given us some really clear answers. For patients who have the most widespread disease, we're talking blockages in all 3 main arteries or that critical left main artery, bypass surgery often gives better long-term results. That means lower rates of death, heart attack, or needing another procedure down the road. And this is especially true for patients who also have diabetes.
So, the main takeaway is this: PCI is an absolutely amazing tool, but for patients with the most complex, widespread coronary artery disease, the durability of bypass surgery often wins out in the long run. It's really about matching the right tool to the complexity of the job.
But the skills and the tech developed for PCI didn't just stay in the coronary arteries. In fact, these exact same techniques, using wires and catheters to navigate the body, have blown open a whole new world, fixing the very structure of the heart itself, all without major surgery.
We are now deep in the era of structural heart interventions. Using catheters, doctors can now close holes in the heart, repair leaky valves, and maybe most incredibly, replace entire heart valves. The #1 example of this is TAVR, transcatheter aortic valve replacement. For patients with a dangerously narrowed aortic valve, we can now thread a brand new valve up through an artery and deploy it right inside the old failing one. It completely avoids open heart surgery, and it has become the standard of care for many, many patients.
And this journey is far from over. As this quote tells us, the field is just constantly pushing its boundaries. What started as a daring way to treat a blocked artery has not only changed that field, but it's now redefining how we fix the heart's valves and its very structure. The question is no longer just what can we do today, but what part of the heart are we going to be able to fix with a catheter tomorrow?